Good afternoon and welcome to our midweek COVID-19 update. Let me go straight onto the screen. And right. So Gauteng, we are doing pretty well, and nationally we are starting to come down. Let me get a pointer up here. Right. But it's a kind of an odd curve, you know. If you look at our first and our second wave, where we had a symmetrical coming down as going up, this is now kind of flattening out. And I think this is largely due to the epidemic, which is quite intense in the Western Cape and in KZN. I'll show you just now. So if we look at this conglomeration of different provinces over here, you see Gauteng in the red, that's coming down very nicely, as is Limpopo, Western Cape going up, and Northern Cape going up, and KwaZulu-Natal. So if you look at the individual provinces, Gauteng, we're doing pretty well. We're coming pretty close to the baseline. Still a little bit of way to go, not quite there, but getting there quite well. So really, the third wave was really governed by the epidemic in Gauteng. And I think this is really showing that the third wave is now coming to an end to a large extent nationally, and I think it will come to an end also fairly soon, hopefully, in the Western Cape and KZN as well. Going back to Gauteng, if we look at the Hatsola data, these are the active cases, again, coming down now, a bit more slowly coming down, and also the new cases also in a fairly downward trajectory. So we are looking fairly good in Gauteng, and hopefully we're coming up for Rosh Hashanah, it'll come pretty close to the baseline, hopefully. Western Cape, not as fortunate as we are in Gauteng, as you see, pretty high. I think it is starting to come down, but we don't want to be too kind of premature in that prediction. You see there are a bit of ups and downs. This is, of course, due to although it is a 7-day moving average of daily cases, there is some kind of variation in how these cases are reported. But hopefully this is starting to come down the Western Cape. Certainly the hospitals are pretty full, and I think they would welcome this curve to start coming down the Western Cape. KZN is still on the upward trajectory, and again, hospitals there are pretty full, and it's a bit delayed after the compared to the other provinces. I just want to say a couple of words about sorry to be on a morbid vein, but about fatalities, because a lot of people have asked me what is meant by the excess deaths. And really, on the other hand, we have the denialists just saying, well, look, COVID is no worse than the ordinary flu. So I just want to give a couple of words regarded to this concept of fatalities. This comes really from the Medical Research Council. What you see here in orange is the average deaths which are predicted. So the solid line is the mean, the upper dotted line and the lower dotted line are the upper and lower prediction bounds. And what you see in the black line are the actual deaths. And these coincide very well, as you can imagine, with the first wave, with the second wave, and the third wave of COVID. So what we got here in the black are the actual cases, the 7-day moving average of cases, aligning very closely with the reported deaths. And this is the estimated background deaths. The background, you can see, goes higher a bit in winter, comes lower down in the summer seasons, goes back up in the winter season. That is mainly due to influenza. But you can see there's quite a gap between that and the red, which are the actual deaths. And in this graph over here, this is where the Medical Research Council feel that this figure, let me come back to it, over here is quite a gross underestimate of the total mortalities. They really kind of are estimating that this is probably about 2 or 3 times at least as high as this. And it's shown graphically on this graph over here. The orange over here is the actual reported COVID deaths, and the green are what we call the excess deaths. In other words, the excess over and above what we'd expect on the baseline. And you can see there's quite a gap between the excess deaths and the reported COVID deaths. So just to give you some bit of background on that. All right, let's look at the vaccination reach. Just under 10 million doses of vaccine have been administered, so we are climbing up. But as has been well publicized in the media, there's now a bit of a lag. We're still trying to get to our 300,000 doses administered per day by the end of the month. And although it has come up a bit, it was about 150,000 at the end of last week. Yesterday, 181,000. So hopefully we are going to get more and more people to vaccination sites. We need to get to that 300,000 as soon as possible. You can see here that there has been the slackening off. One stage we were close to 300,000, with 275,000, and now down to 180,000. Again, I think I did show this last time, but just to again emphasize, there's a big gender difference. It's about a 60-40 ratio with men really lagging behind in terms of vaccination coverage. Also, what's a little bit concerning is this in the green over here, which reflects the vaccination coverage in the key group, in the 60 plus, in the older group. That's the group that we're really targeting. And unfortunately, it's not much above 50%. We really need to get that group well into the 80% if we're going to stop the being overloaded in the hospitals and people getting severely ill, and the mortality, of course, as well. So this is what it looks like. The 2 million doses, just over 2 million of the Johnson & Johnson, the one-dose vaccine, and 7.5 million of the two-dose Pfizer vaccines, broken up into 5.4 million doses of people who have received the first dose and 2.1 million who received the second dose of Pfizer. So if we look at this table over here of the vaccination status, where we are at the moment, we are creeping up. Fully vaccinated, 10.8% of the adult population, 7.2% of the total population. Partially vaccinated, fully vaccinated means one dose of the Johnson & Johnson or two doses of Pfizer. Partially vaccinated, one dose of Pfizer, 13.6%. In terms of the total number of individuals who are vaccinated, because remember, some of the fully vaccinated are also incorporated into the partially vaccinated, it's 7.6 million people who have been vaccinated with either partially or fully vaccinated. And that's about 19% of the adult population. So there's still way to go before we're going to reach anything approaching community immunity or herd immunity. Without what the exact figure is, the threshold, we still not quite sure because of the Delta variant, the highly infectious Delta variant. This is a very nice graph over here, and a very nice picture, I should say, of a schematic view. The virus obviously doesn't look exactly like this, but just these waving green things over here are the spike protein. That is really the kind of key protein of the virus that attaches the virus onto the receptor sites in the body. If these are the receptor sites, these are the spike protein, and that allows the virus then to enter into the cells and start the infection. So really what we're trying to do, or what the researchers are trying to do, is trying to get vaccines designed which are going to attack this particular spike protein. Remember, the spike protein is what stimulates the immune system, and that's really what governs the effectiveness of the vaccine. And it's this part over here is called the receptor binding domain. This is really what the actual key part of the spike protein, which attaches to the receptor sites on the cells of the body. And it's really the variation of this receptor binding site plus one or two other parts of the spike protein, which when they vary, allows these variants, when they mutate, they allow these variants to occur, and that either escapes the effect of the vaccine or alternatively it makes the virus more infectious because more of this can attach to receptor sites. or else it may cause more severe disease. And this the virus is protected by these sugar molecules over here. So what our next generation of vaccine developers are trying to do is trying to get to parts of the spike protein which don't vary so much. We call it conservative parts of it. And that is really, hopefully, in the future, which are going to attack or going to combat the ability of the virus to escape vaccine immunity by designing vaccines specifically to conservative parts of the spike protein. I'll go into a little background on that. All right, I think I'll stop over there and go into some of the questions. And again, many thanks for the questions which you do come in. I'm going to try and cover as many as I can, but I really have got many questions. So let's kick off. There's the question which came in. I have got quite a few questions. Are people that are either on blood thinners or people that do have had blood clots or thrombosis in the past, or people who have got some questions here on people who have blood clotting disorders. Protein S deficiency was the one which came to me, Leiden factor. These are various individual blood clotting problems where people either get thrombosis or clotting or have bleeding disorders. Now, we do know that there have been very rare side effects of the vaccine, particularly the Johnson & Johnson vaccine, and to a greater extent, in fact, the AstraZeneca vaccine, not being reported with the Pfizer vaccine, is this rare complication of thrombosis. When I say rare, there have been various studies, and it varies between about 2 to 4 cases per million doses. A little bit higher with the AstraZeneca as compared to the Johnson & Johnson vaccine. So the Johnson & Johnson between 1 and 2, and the AstraZeneca between 2 and 4 per million doses. Very rare. A little bit higher in younger women between the ages of 18 to 50. There it's about 5 per million. So if there is women in that age group who have had a history of thrombosis, we may want to, as a precaution, advise them to get the Pfizer vaccine. However, having said that, I think because these complications are so rare, it's really nothing to worry too much. But I think if a woman in that category, younger women who have had thrombosis, it may be advisable to advise the people at the vaccination site of that, and also to kind of follow up, because it can be treated. This complication is actually called VIT. The technical term is vaccine-induced thrombocytopenic thrombosis, but don't worry about that. What it means is that it's clotting as a result of the vaccine as this rare complication. Now, the thing is that the mechanism of the clotting, in fact, is quite different to all these blood dyscrasias with these blood pathologies which I mentioned, people who tend to have clots, who had that thrombosis in the past, who are on blood thinning medications. So it's a different mechanism. So it's really nothing to be too concerned about. As a precaution, try and get the Pfizer instead of the Johnson & Johnson. And if one does get either persistent headaches, which is the one manifestation of this complication, or persistent abdominal pain, to alert the doctor, because it is treatable. There have been very few fatalities. I think it's far less than 1 per million, but there have been a few reported. But it is treated if it can be started, the treatment can be started quite early. All right, then another question arises with regard to the household outbreaks. And there have been quite a number of it. It starts off with one member of the household, and then there's a cascade infecting various other members. Now, when can you kind of de-isolate in that situation? Well, firstly, the first member that does get proven COVID, all the other members in that household are by definition contacts, and they should be quarantined as far as can be done. They should be, ideally they should be in quarantine hospital, but obviously that's not practical. So they should be isolated from the first case in a family. Usually what will happen is that 1 or 2 other members will also get infected. So when can you de-isolate? You can de-isolate after the last person that is ill 10 days after they start getting. So the usual situation of isolation of an infected person. But here you got to take the last person that gets ill. Hopefully, other people that don't get infected will have been isolated. If they're not, then of course they remain as contacts, and they would then have to quarantine for a further 10 days if they're not properly isolated from any of the ill cases. So I hope that makes it clear. Let me just summarize it again. You isolate from the last person that is ill for a period of 10 days after the onset of the illness or after when they test positive. And any members of the household that have not properly quarantined, they are by definition contacts. They would need to isolate for a further 10 days after the last ill person has recovered. Okay. Then I have had a number of queries, and this is something which at the advisory committee we are still debating, we are still investigating. And these are the young individuals. As you know, at the moment it's 35 years and upwards, but there are a reasonable number of people, not many, because most of the comorbidities will be in the older group, but younger people who do have comorbidities. At the moment, unfortunately, there is no provision for them to get vaccinated on the official electronic vaccine data system, the EVDS. We are working to try and have these people. So if there are individuals who are in the younger age group who do have severe comorbidities, not the milder asthma, so we're talking about severe comorbidities, their doctors may write a motivation letter and we'll try and take it up. At the moment, unfortunately, there isn't provision for that. Then a number of individuals have asked, can they get a booster Pfizer if they've had Johnson & Johnson for the priming for the first dose? As I've just mentioned earlier, the Johnson & Johnson is really a one-dose vaccine. Now, I know many of the healthcare workers are agitating to have boosters. The data at the moment, the knowledge, the scientific evidence is that at this stage, it is not necessary. There is still robust, durable immunity, which has been actually measured up to 280 days, and it's not necessary to have a booster. The issue of having a booster after Johnson & Johnson with Pfizer has not really been determined at this stage. The only data that we do have is a booster, Pfizer booster following AstraZeneca, which we don't use in this country. And that works very well. There's a great stimulation of the immune system if you have Pfizer following AstraZeneca. There are trials going on with a Pfizer booster, to Johnson & Johnson, but the data is not yet out. So we need to look for two things. First of all, is it going to improve the efficacy, improve the immunity? And also we need to look at safety signals. The Pfizer following AstraZeneca seems to be pretty safe. And probably, almost definitely, Pfizer following Johnson & Johnson will also be safe, but that still also does need to be absolutely established. I did get a question from one of the viewers about graphene oxide, which is a poison, a toxic material in the vaccine. There's absolutely no truth in that at all. The ingredients of the vaccine are absolutely innocuous. There's no penicillin, there's no sulfur drugs, there's certainly not graphene. I think this is part of the anti-vaxxer activist conspiracy theories. These vaccines are extremely safe. Their constituents are rigorously examined by the regulatory authority. And you can be assured that they are not only very effective in reducing severe disease, but also very, very safe. These side effects that I mentioned, the clotting, are extremely rare. The myocarditis, inflammation of the heart, very, very rare. And much, much, much rarer than the complications of COVID disease. So please get vaccinated if you haven't already been vaccinated, and go to the vaccination site. You're doing yourself a favor and you're doing your community a favor. Thank you very much. Goodbye.